Emergency Medicine channel. Today I'll be briefing you about the topic hypothermia. Coming to the definition of the hypothermia, hypothermia is called when the core body temperature falls below 35 degrees Celsius or 95 degrees Fahrenheit. Coming to the pathophysiology of the hypothermia, there are mainly four mechanisms in the human body through which we lose our heat. So the main four mechanisms are the conduction, convection, evaporation and radiation. Conduction is that when we come in contact with a cold object, we have the heat loss. So that is known as conduction. Convection is when there is a direct contact with the cold air, cold wind and cold fluids, we lose the temperature. So that is known as convection. And coming to the evaporation, it happens when there is a state change, that is when there is a change from liquid state to the gaseous change, then we call it as evaporation. And radiation is when a warm object loses the heat through electromagnetic rays. So these are the four pathophysiology mechanisms how our body loses the heat.
Okay, so you told that definition temperature less than 35. So what temperature?
That is the core body temperature, less
Temperature.
than 35 degrees Celsius.
That means
or
patient's body temperature should be less than 35 degrees Celsius. Okay. And then pathophysiology, when you are telling conduction is solid to solid. So we will consider ourselves as solid, and if the patient is leaning against a metallic wall which is very cold, so solid to solid is conduction. Convection is through air, like wind or any water, that is convection. And evaporation is from our bodies, this thing is getting evaporated. And radiation. Okay.
So these are the mechanisms how we lose the heat. Now coming to the causes of hypothermia, so they can be accidental causes and the therapeutic causes. Accidental causes are the most common, and by meaning therapeutic causes is that if there is some ischemic event ongoing in the body, in order to prevent the tissue damage, we usually have the therapeutic hypothermia. That is the one cause. And the second main cause is the accidental cause. In accidental cause, we have the primary and secondary. Primary cause is the environmental change. When there is an when the temperature goes down, we lose heat, and that is known as primary cause. Coming to the secondary hypothermia, the main causes are when there is predominantly increased heat loss in our body. That is, the main causes will be if in case of burns, in case of recent birth, and iatrogenic causes like when we are giving the patient multiple blood transfusions, when we are transfusing with cold fluids, when cooling blankets are given, and when patients comes to our ER if we are not giving inadequate insulation, all these can cause more of heat loss, and then patient can develop hypothermia. The second mechanism is the predominantly impaired thermogenesis. That is that in our body we will be impaired of making shivering. That is, if you take the age group of the patient, in more advanced or in very young age group, if the patient is having some malnutrition, if there is any history of physical exhaustion or any neuromuscular disease, then the protective mechanism, that is shivering, will not be there, and then patient loses the temperature. Then the other causes, multifactorial, these are the most common causes, such as if there is any medications or toxic medications, like if any anesthetic drugs are given, if any sedatives are given, if any narcotics are given, then that also can cause. Toxics like alcohol, etc. also can cause. Then coming to the metabolic and endocrine disorders such as diabetic ketoacidosis, the alcohol ketoacidosis, in cases of hypoglycemia, hypothyroidism, hypopituitarism, in case of Wernicke's encephalopathy, all these also you can see the temperature loss. Then other less common are the sepsis, shock, and other one reason we commonly see in our ER will be the trauma cases. And also in neurogenic causes such as if there is any spinal cord injury, if there is any space occupying lesions, or if is stroke, then also patient can go into secondary hypothermia. So these are the most common causes.
There are acute and subacute causes. So if you are talking about acute causes, like especially not in our climate area, especially exposure to immersion into cold water, that is an acute cause. Then other acute cause can be exposure to an avalanche in a snow area, that is acute cause, and in this setting the patient will go into hypothermia within 30 minutes, that is acute. And subacute means little bit slow, and subacute is usually seen when all can you expect subacute?
Like if there is any metabolic causes, if the patient is having any sepsis, if when patient goes into shock, in cases of trauma, all the subacute.
So subacute usually happens if the body is in hypovolemia, or if the patient is energy reserves are very less. In that case also patient will have subacute causes. Then there are some causes like subchronic causes. Chronic means slowly this will set in, subchronic causes. So in our part of the in our areas and all, we usually see subchronic causes. Like patient might have had a fall in the washroom. The patient might be lying there for many time. Then slowly patient will go into hypothermia. There might be some water in that washroom. Or patient had a fall outside, nobody noticed that. Patient was lying there for lot of time. So patient had a fall, patient was not able to walk, such things. That environment also will contribute, and that will cause a hypothermia. Then age, based on age, can you tell who is more prone for hypothermia?
Both extremities of age group are more prone. Either very young and or very elderly people develops hypothermia.
Young,
because in young the surface area will be more compared to their body mass ratio. The surface area will be more, so the heat loss will be more in the pediatric.
And their energy reserves also will be less because they are more active. Already their energy reserves will be very less. Then in elderly because their heat production will be impaired, there will be increased heat loss, and that thermoregulatory centers might be malfunctioning. That's why elderly are more prone for hypothermia. Okay.
Now coming to the cold physiology, that is when the patient develops hypothermia, what all changes are going to happen in the patient. Coming to the CNS system, here initial phases patient's judgment will be impaired, patient will be going into ataxia, patient will develop memory losses, then ultimately patient will develop unconsciousness, and there can be an arrest in the patient, electrophysiographical arrest can happen. And when the temperature goes below 29 degrees Celsius, the pupils will become fixed and dilated. So when a patient arrives into your ER, never take a decision based on the pupils, because once the temperature goes below 29 degrees Celsius, the pupils will be fixed and dilated. Then when the temperature goes below the 23 degree, your corneal reflexes also will be absent. These are the things that is happening in the CNS. Coming to the CV system, initially the patient will be having tachycardia and the BP will be shooting up, because as a result of temperature loss there will be vasoconstriction. Protective effect of our body will be vasoconstriction. So vasoconstriction will happen and your heart rate and BP will initially go up. And following that, these things will start to, they will be deteriorating, and patient will go into hypotension and bradycardia. And also when the temperature goes below 32 degrees Celsius, the patient will be prone to have a cardiac arrest. And then here you have to understand that in the patient there will be many dysarrhythmias happening. So the most common dysarrhythmia will be happening.
Did you mean initial hypertension?
It will be going up.
Initial high BP, then
it will come down. And then a patient will be most commonly having atrial fibrillation and the flutter. So also bradycardia. So when a patient comes to our ER and have these such of dyselectrias, we never correct them, because we have to initially correct the hypothermia, and not these specific treatments has to be given to the patient. And then coming to the ECG in the CVS system, in the ECG we will be...
before going to ECG, here you told initially there will be tachycardia and hypertension, then we will go into bradycardia and hypotension, and there is also chance for pulmonary edema. Patient might go into pulmonary edema, and that will cause an arrest. Okay, that will cause a cardiopulmonary arrest in that patient. Okay.
Then coming to the ECG changes, as we can see here, the patient will go into Osborne waves. That is, at the junction of the QRS complex and the ST segment, there can be a elevation. So this is the classical finding what you can see in hypothermia in the ECG. This Osborne waves can be seen in other multiple conditions like hypercalcemia, or in case of MI, Brugada syndrome, all this also we can see. But in hypothermia, this is one of the classical finding we will see in the ECG.
So how will you differentiate between this? So, this looks like an RBB pattern. There is a R wave, there is an S wave, and also another R wave. So it looks like a R, S, R dash pattern. How is it different from a right bundle branch
If
block.
it is an RBBB, usually the R dash will be more peaker than
Can you just draw?
if this R dash, usually if it is an RBB, it will be more. So it will be
You
more
can
peaker
draw
than the
that.
R. Usually this will be R dash will be more peaker than the R. So but in case of Osborn waves, it will be lesser than the R wave. R dash will be smaller than the R wave. That is how we differentiate between the Osborn waves and the RBBB pattern.
Okay. Then what other change can you see in ECG? When will you start seeing this Osborn waves?
Once the temperature goes very low and it has been for some time, then the ECG will show this variation.
There is no specific cutoff as such, but it is told that if the temperature is less than 33 degrees Celsius, we will see Osborn waves. Osborn waves. And if the temperature is less than 28 degrees Celsius, patients are prone for VF. And if the temperature is even going below like 22 and all, patients are more prone for asystole. Okay.
So here in this ECG, the usual findings like AF can be seen, and also muscle tremor artifact is usually seen when the patient is having a hypothermia with Osborn waves.
Okay. Other than Osborn, any other changes? Osborn is a typical change, but other than that, you can see something else like there will be prolongation.
There will be prolongation of the PR, widening of the QRS will be there, then Osborn waves also will be there.
Then widening of QT interval
QTC prolongation also will be there.
And RR also will be prolonged. All these four things will be. So PR will be, initially prolongation of RR will happen, then PR interval prolongation, QRS,
widening,
QT, everything, and patient also will have bradycardia. Okay. Then Osborn waves. These are the changes. Okay. So any close differential diagnosis for this Osborn waves? One is this.
If there is any electrolyte imbalance, that is hypercalcemia.
Hypercalcemia. Any wave which is similar to this Osborn wave?
Early repolarization wave in case of M.
Benign early repolarization. So one benign early repolarization. Other one is the RBB pattern for right bundle branch block. Then any other waves? Okay, Brugada will look like an RBB pattern. Any other wave? Delta waves will be seen in WPW syndrome. So delta will be looking like there will be a P, and if it is a WPW syndrome, the PR interval will be small. Then you will be seeing a this thing, delta wave, a QRS. This will be a slanting. Okay, and the T. Okay, that is WPW syndrome. That is a delta wave. One more wave. One more wave is the epsilon wave. Epsilon wave. Okay. One second. Epsilon wave. Epsilon wave is usually seen in cardiac condition only. So what will happening is this. What wave is this one? RSR dash. This is for RBBB. Then you will be seeing this wave which is smaller, which is somewhat that means this is J point elevation which is seen in our Osborn waves. Epsilon wave will look like this. Especially where all will you notice this? Which lead will you notice this RBB pattern, J point elevation?
V1, V2.
Mostly in the right side at chest lead. So in the V1, V2 that region. Here in epsilon wave is usually seen in arrhythmogenic right ventricular dysplasias. So what will happen is this right ventricle will be having a delayed electrical activity. So because of that, after the QRS there will be a it looks like an estiolation. It looks like this part looks like an M over this region. So this is because of the right ventricular pathology. So this is called as an epsilon wave, and when we are looking, this is seen in V1, and when we are looking in lead 2, it will be usually looking like this, like another up. So this will be mistaken as an Osborn wave. Okay, so that is a one DD.
So these are the ECG changes. Then coming to the changes in respiratory system, patient will also go, initially patient's respiratory effort will be increased, patient will be having tachypnea. Later the minute ventilation will start to come down and then patient will go into respiratory arrest. Patient can also develop pulmonary edema. Then coming to the metabolic changes
And
in
one cause is because of the restrictive pathology. If the patient is exposed to very much cold area, there will be a restrictive lung pattern, like especially in freezing temperatures and all. So that's why patient won't be able to breathe.
Then coming to the metabolic changes in the hypothermia, patient will have renal diuresis, that is cold diuresis. We term it as cold diuresis because initially there will be a vasoconstrictive phase, and then when the fluid will be going into the renal perfusion will be there, and this in renal perfusion the kidneys will try to push out the cold fluid, and then patient will have cold diuresis.
I think we all might have experienced that. If we are in a cold room, we all will feel like passing urine.
Then the second one, patient can develop rhabdomyolysis, frostbite. Then patient can develop pseudo-rigor-mortis. This thing also we have to know pseudo-rigor-mortis, because when a patient comes to the ER with features of rigor mortis, we shouldn't think that the patient had been in arrest for many hours. So this is an initial change and this will be a pseudo change in the patient. So you have to resuscitate the patient knowing that this is a pseudo change in hypothermia. Then a patient also can go into coagulopathy. That is because here patient will be having patients go into hemoconcentration. Hemoconcentration, thus viscosity also will be increasing, hence patient will go into coagulopathy also. So these are the changes happening in the hypothermia. Now coming to this, when a patient comes to our ER with hypothermic changes, we have to classify the patient into mild, moderate, severe and hypothermic cardiac arrest. This can be also known as stages of 1, 2, 3 and 4. So
What is this classification known as?
This is the
Swiss classification. Oh, okay, you can tell.
So in mild hypothermia, the patient's clinical symptoms will be, patient will be conscious and patient will be having shivering. So the temperature, core body temperature will be between 35 to 32 degrees Celsius. So here that is the first class. Then second class is the moderate. Here the patient will have an impaired consciousness and shivering may or may not be present, and the temperature will be between less than 32, that is from 28 to 32. Now when the temperature is below 28 and when patient is unconscious but the vital signs are present, we term it as severe hypothermia, and the last stage is where the vital signs are absent and the patient is coming in cardiac arrest. So these are the classifications of hypothermia. So then when a patient comes to your comes to our ER, we have to classify, like initially we look for the vital signs. If the vital signs are present, then we are going to look for the consciousness. So if consciousness is preserved, then you will be terming it as hypothermia class 1. Even if the consciousness is preserved but the patient has history of trauma, if there are major comorbidities and if there is any suspected secondary cause of hypothermia, we will be putting them under hypothermia class 2. So if the patient's consciousness is impaired, then straightly it will come under hypothermia class 2. Then the 3 and 4, 3 is when the patient's patient becomes unconsciousness but vitals are preserved, then we will put it in the hypothermia class 3. And if the patient's vital signs are absent, if it is absent, then it will be under cardiac arrest, impending cardiac arrest, or the patient coming in cardiac arrest. So that will be put in the hypothermia class 4. So this is the triaging. Now coming to the evaluation, when the patient presents with hypothermia, initially you have to look for the core body temperature. So we look for the core body temperature. If the patient has been intubated, then you can put the esophageal probe and see. So you will be putting the esophageal probe in the lower esophagus, that is below.
So one thing you need to note is that we are not just measuring the patient's body temperature. We need to look for the core body temperature. Okay, so for that you need to different ways are there. If you are intubated,
then you can put look into the esophageal. You will be looking into the lower esophagus, that is below 24 centimeter you will be looking. Then the second method is you can use rectal probes. If you are using the rectal probe, then you should introduce more than 15 centimeter. Then you can use the bladder probe, but bladder probe is the less preferred one, because if you are rewarming the patient, then that rewarming temperature difference will be not shown in the bladder, and also if you are giving some lavage through the bladder, then the temperature will be shown as higher temperature. So that is not much reliable. So we mostly prefer the esophageal or the rectal measuring. So you have to monitor the core body temperature of the patient. Then next comes the blood glucose levels. Then as we have already told, we have to take an ECG and look for the ECG changes. Then if we are going to suspect any pulmonary edema, then you have to look for the X-ray. And after all these preliminary evaluations being done, we have to rule out the secondary causes of hypothermia. So as we have told, we will be looking for the CBC, CRP, the blood gas, that is to look for the lactate levels, the electrolyte levels, the creatinine levels in the patient. Then you also have to look the anion gap, because we know that decay everything can cause. So anion gap, toxins, for toxins we'll be looking the osmolar gap. Then to rule out rhabdo, we'll be looking for the total CK, and if you are suspecting any sepsis, shock, anything, we'll be also sending the blood cultures of the patient. So these are the important evaluations to be done if the patient presents in hypothermia.
And complications of hypothermia, like DIC is expected. So you need to look for the fibrinogen, the PTINR, APTT and all
these things. Now coming to the treatment as such. So we'll be dealing with the treatment. So in the first class, that is if the patient is presenting with mild hypothermia, we just need to give a warm environment and warm clothing. So we'll be also giving warm drinks to the patient, and then if the patient is possible to move around, we'll be asking the patient to do active movements. So that is one what we do in class 1.
So if the patient is wet, we need to first dry the patient, then give warm
clothes. And then as we have told previously, if the patient is having any significant trauma or major comorbidities, or if we are suspecting some secondary causes, that patient will be put under class 2 or the moderate. And when the patient comes under moderate group, whatever we have told in the class 1, that has to be done. That is, make patient dry, give a warm environment, all those things has to be done. Along with that, we will be preferring active, external and minimally invasive rewarming techniques. So that is, you can see here, this is the one of the minimally invasive rewarming technique, that is the hypothermia brochure. In this, what we do is, we have 6 protectors for the patient. So the first one will be the outer wind and the waterproof. This is the first one, outer wind and waterproof wrap will be there. Then secondly, we will be giving a insulation or the heating pad. Then you will have to replace all the wet clothes, and then wrap, if possible we will be wrapping in plastic. So we will be wrapping in them. Then we will be giving a forced air or chemical or electrical heating device will be kept, and then an insulating blanket will be covered over the patient, and then we will be also insulating the head region. But if the patient is in cardiac arrest, we shouldn't apply heat to the head. So these 6 layers of protection will be given to the patient in rewarming. This is the active, external, minimal invasive rewarming technique. So that has to be given to the patient here, and then we will be doing cardiac and core body temperature monitoring, and also we have to avoid all the dysrhythmias by rewarming the patient, and we will be giving the full body insulation, and here we will be immobilizing the patient. In class 1 we are asking the patient to move actively. In class 2 we will be immobilizing the patient.
Why?
Already we are keeping in the full body insulation.
Yeah, 2 things are there. As we told, this patient, we told Osborne waves might come if the temperature is going less than 33. So they are highly prone for arrhythmias and hypothermia induced cardiac changes. So for cardiac monitoring, okay. So we don't want patient to go into arrhythmias. If the patient start moving, the heart rate will increase. So for cardiac monitoring, we shouldn't move the patient. Second thing is, patient might be in impaired consciousness. So in that case also, we shouldn't move the patient. And another thing is that we anyway want the patient to be covered. So for that reason, and also here we can also use that radiant, some light sources which can give more warmth. There is, so radiant warmers can be used, and also light sources also can be used. And here also we can do the other things like the what are the other things? Like
Warm blankets can be given,
Warm
warm fluids
fluids.
can be given, lavages. Usually previously we used to give lavages, rectal lavage, peritoneal lavage, and even in case of impending cardiac arrest, thoracic lavage was given for the patient. Nowadays we don't prefer, we prefer the other method of giving. Then if in this case,
then intubated patient, warm air should be
given. Then in case the patient is going into hypertension, here usually we don't prefer giving vasopressors because already the body has gone into vasoconstriction. So we will not prefer giving vasopressor. We will be giving warm fluids, looking the fluid status of the patient. Initially you can give 10 to 20 ml per kg, that is around 1 liter bolus can be given, and following that 10 ml per kg fluid can be given, and it should be of the temperature 38 to 42 degrees Celsius. Warm NS is what we prefer. And then even with that, in the rewarming stage, even after the fluid resuscitation, if the patient is not picking up the BP, that is, it can be due to vasodilatation, then you can start on vasopressors. So the first stage you don't prefer vasopressors. And in this case, if we are not able to rewarm the patient, if there is a failure to rewarm the patient, then you have to look for the secondary causes of hypothermia. Then coming to the severe hypothermia, where the patient is unconscious but the vital signs are present and the temperature is less than 28 degrees Celsius. Here also all the previous told steps should be done. Along that, we will be protecting the airway, and also if the patient is intubated, then we have to maintain a PaCO2 of 40, or if PaCO2 we are not able to look, then EtCO2, normal range EtCO2 should be maintained. And if the pH is very low and if there is acidosis, if there is a proper indication, only bicarbonate should be given to patient, otherwise it should not be given. And we will be preferring to transport the patient to a ECLS center, that is extracorporeal life support, where there is availability of ECMO. We will be shifting the patient to that center. So when should we give an ECLS to the patient in severe hypothermia? That we have some criteria, that is, if there is a failure to improve with the external active and minimal invasive rewarming methods, if there is life-threatening dysrhythmias, if there is hypotension, that is systolic BP less than 90, if there is a respiratory failure or any refractory acidosis, in these cases we will be preferring for ECLS, and we will be shifting the patient to a ECLS center.
Okay, and provided that the patient's temperature should be less than, core body temperature should be less than 32 degrees Celsius, and also the potassium level should be less than 12, or some textbooks say, UK guidelines say 8. So 8 millimoles per liter. So if this criteria is getting satisfied, only we will be planning. And if a patient is coming with a core temperature like less than 13.7 degree and all, it is considered as an irreversible change. So such patients, there is no point in resuscitating or planning such things.
Then coming to the fourth stage, that is the hypothermic with cardiac arrest. So whenever the patient's temperature goes below 32 degrees Celsius itself, there is a possibility of having cardiac arrest, and when the temperature goes below 28, there is high chances of having the cardiac arrest. So here what we do is, as soon as the patient comes, we start giving the CPR to the patient, and then if possible, if the ECLS center is within 6 hours of transportation, then we will be trying to shift the patient to a center where there is ECLS. So here we will be doing we'll be directly shifting the patient to a ECLS center, and we'll be starting CPR, and also along with that we'll be preventing further heat loss. And according to the textbooks, previously we used to prefer thoracic lavage. By putting 2 chest tubes, we'll be giving lavage to the patient. And when we give CPR in these patients, the changes that we have to know is that the compression ventilation rate will be same as of the normal CPR, same rate we will be giving to the patient. If the patient has VF, then we will be shocking the patient. Maximum up to 3 shocks can be delivered to the patient, and if then also the patient is not getting revived, then stop shocking the patient until the temperature improves to 34 degrees Celsius. So up to that only 3 shocks can be delivered to the patient, and when the up to the body temperature becoming 30 degrees Celsius, adrenaline is not indicated in the patient. You shouldn't give adrenaline. Once the temperature is above 30 degrees Celsius, from 30 degrees Celsius to 34 degrees Celsius, you can give the normal dose of adrenaline, but the interval will change. Usually we give in 4 minutes. So here it will become 6 to 10 minutes interval we will have to give the adrenaline. So these are the changes in hypothermic cardiac arrest resuscitation.
And some more, one is that we need a core body temperature measuring thermometer. Then another problem is that we have a compression ventilation ratio 30:2. The problem is that the chest will be very much restricted because of the severe coldness. So this compression will be difficult. The CPR will be difficult. So ideally in colder areas we need a mechanical CPR giving device. That device should be required, otherwise the person who is giving the CPR will be in fatigue. Then VF, in case of VF, maximum 3 shocks will be given till the temperature becomes more than 34 degrees Celsius, and adrenaline you have already mentioned. Then anything else in the cardiac arrest management? How much time should we look for the pulse? Usually in a cardiac arrest, how much time will you check for
Every
a pulse?
2 minutes you will be reassessing the patient.
No, how much time will you be checking?
Less than 10 seconds.
Less than 10 seconds. But here we need to look at least for 1 minute. Palpate for at least 1 minute. Then anything else? Then another thing is that, this thing is there, core body temperature should be measured, and prolonged CPR. Prolonged CPR is required because we cannot declare death until and unless we treat the hypothermia. So prolonged CPR is required. Pulse should be checked for this much time, and this shocks of only maximum 3 shocks till the temperature improves, and this adrenaline also we should consider. So what is the dose of adrenaline which you give?
1 mg will be given.
Same
Same
itself. And where will you place a cannula? So during resuscitation, where will you plan on placing the cannula?
It should, if you are putting a central line, then the tip of the catheter should be away from the heart, and also otherwise you can put to the peripheries. We don't prefer.
Ideally, there always when you are placing a central line, there is a risk of the guide wire going into the heart and causing arrhythmia. So here we don't want that to happen. So ideally, it is better to always place a femoral line for giving medications. Okay.
Now this is the guidelines for when to terminate the resuscitation what we are giving. So if there is an obvious sign of irreversible death, that is if there is any decapitation, if the body has already become frozen solid, if there is decomposition if any of these are present in the patient, then you are going to terminate the resuscitation. If these are not present, but there is cardiac arrest and there was an alternative cause which caused cardiac arrest prior to the cooling event, then also we can consider of terminating the resuscitation. Then some special circumstances are there, that is in cases of drowning, avalanche and trauma. In cases of drowning, as we know that the main cause of cardiac arrest will be hypoxia. So in those cases also, if the time duration is longer and prolonged, then we can consider termination of resuscitation. In cases of avalanche, if the time duration is less than 35 minutes, the cause of cardiac arrest will be hypoxia or trauma. And if it is more than 35 minutes also, we can consider termination. If it is less than 35 minutes, we have to continue. But if it is more than 35 minutes, you can consider the termination.
And one more thing I forgot to mention in the cardiac arrest management is always plan for an early intubation. Not at all in cases of drowning and all cases of hypothermic cardiac arrest, we usually plan on intubating the patient once ROSC is achieved. So in this cases, intubation and giving bag and mask, especially warm air and all, will help in increasing the core body temperature. So always consider early intubation. Okay.
Then other than these, the next 2 points will be the if the core body temperature is already more than 32 degrees Celsius and the serum potassium level was more than 12 millimoles per liter, then also you have to consider the termination of resuscitation. Then if all these things are not there but the transportation time for to an ECMO sender is within 6 hours, then we'll have to start the CPR on the transportation, and then we have to transport the patient to an ECMO center. But if otherwise, if there is no ECMO center within 6 hours of transportation, we will be taking the patient to a nearby hospital and we will be continuing prolonged CPR. Here you will have to perform the prolonged CPR. We can't terminate unless we have doing prolonged. We can't terminate the resuscitation
till we rewarm, or maximum. Or a minimum of 40 minutes.
40 minutes. Till that we will have to resuscitate the patient. So this is when we will terminate the resuscitation guidelines. Then coming to the complications, we have complications of early complications and late complications. Early complications will be during the rewarming procedure. That is, we have already told that cold physiology, whatever happens in each system we have told, those will be the early complications. And coming to the late complication is that post rewarming. In respiratory system, as we have told, there will be pulmonary edema, infection. In CVS, patient can go into hypotension and patient can develop dysrhythmias. Coming to the CNS, patient can have seizures, there will be low cognitive function, then patient can go into persistent vegetative state because we are doing CPR for a prolonged time, so patient can go into vegetative state, and also patient can develop multi-organ failure. So these are the most common complications post this hypothermia resuscitation. And coming to the disposition, that we have already told, if it was a primary cause, that is due to the environmental changes, if the patient had gone into hypothermia, just rewarm the patient, and once the temperature becomes normal, you can discharge the patient and follow up the patient.
So when will you reassess the patient? Like if the patient is in mild hypothermia, when will you reassess the patient, the temperature? Mild, we can reassess every 15 minutes. Okay. If it is moderate, we will have to reassess every 5 minutes. And in case of severe hypothermia, cardiac arrest, continuous monitoring should be there.
And then if in cases of secondary causes, all patients has to be admitted and treated. And coming to the pediatric, in pediatric, as we have already told, the surface area will be more, so their heat loss will be more. So here you have to give rewarming for a longer duration, and also if you are initiating CPR, it has to be prolonged CPR in the pediatric age group. So these are the main things regarding the hypothermia. Thank you.